Almost 1.5 hours, but we'll start for the discussion. I've known Marco for a very long time, and he's a very dear friend, and he runs a very good clinic in Italy, and he's doing an excellent job to rheumatology. He was a past ILAR Secretary General, and he is an excellent rheumatologist at the same time. Now we have been speaking about osteoporosis for the last 15 years, and sometimes during the lifetime we have to stand, evaluate, and see what have we done, what have we achieved, where did we go wrong, and what are we going to do in the future. And this is why I've chosen the topic, where do we stand now? This is the current definition of osteoporosis. The old definition entails that there is loss of bone mass, eventually leading to fractures, but this new definition have acquired a political terminology which is compromised bone strands. That means that the strength of the bone is not as good as it should be, but it is not as bad as it happened, and it depends on bone density and bone quality, and I prefer that this will predispose a patient for fracture at the same time. Drug companies have a huge market for drugs for osteoporosis. For example, the market now is valued almost $10 billion in 2009. It's expected by the year 2017, this market will jump up to $18 billion. And this is because there is increased prevalence of osteoporosis. We diagnose osteoporosis more, and the female population, they are the principal driver of this increase, because since we are not using hormonal replacement therapy, HRT, like before, after the Women's Health Initiative study and the complications of HRT, we have to find other ways of anti-resorptive drugs or bone-based drugs to try and help the patient instead of having HRT and its complications like stroke and heart attacks, breast cancer, and blood cancer. We live longer, and this is why we are hit by osteoporosis, and it hits us usually when we are old. Now, osteoporotic fractures are coming on the top of the list, and you can see here that the annual incidence for 1.5 million fractures. You can see that there are 2,050 hip fractures, 2,050 forearm fractures, and 2,050 other sites, and 750,000 vertebral fractures. This means that vertebral fractures are the most common. If you compare this to other diseases like heart attacks, strokes, and breast cancer, you find that the incidence and the prevalence is much less. So how do we diagnose osteoporosis and rely on our diagnosis? We have bone measurement techniques. We have the dual energy X-ray absorbed to the DEXA, quantitative tomography, ultrasound, and high resolution QCT. The most commonly used one is the DEXA machine. This is the standard method for measuring the bone density, but it has its limitations. It's unable reliably to differentiate between cortical and trabecular bone because we measure the bone as it is, and at the same time, it measures, or it provides a measure. It provides a measure for the area, that particular area of the bone at that particular time, and this is why we call it areal bone mineral density. And this is why you can measure the BMD. It gives you an idea, but it's not as accurate as it should be, but it is definitely far better than the X-ray. The WHO had set criteria for osteoporosis in reference to same age, more or less. If you have a T-score of -1 to -2.5, you have a low bone mass and you are designated osteopenic. Less than -2.5, you are osteoporotic, and -2.5 and one or more fractures, you are definitely having established and severe osteoporosis. Based upon this, we should expect that most of the fracture will occur here when you have established osteoporosis. Some of it will occur here, but at this area between -1 and -2.5, we should not expect fractures. But the actual stage is different. This is the DEXA machines, how it shows arm measurement size. This is the femur, and this is the forearm. We have problems in interpretation of the bone mineral density by DEXA. It does not diagnose osteomalacia. The only thing which diagnoses osteomalacia is either you do a bone biopsy or scan, bone scan, and this is the only thing. And we see patients with rheumatoid arthritis in group 45, they are having both osteomalacia and osteoporosis. Because we know osteoporosis does not cause pain, but osteomalacia is a painful condition, and this is why many of our patients complain of having bony aches and bony pains. Osteoarthritis gives us a misleading results because if it overlaps on the vertebra, it gives a false measurement, vascular calcifications, metal objects, contrast being in the spine, previous fracture because at the vertebra, the edge of the vertebra is superimposed in the body, it gives a false reading, severe scoliosis, vertebral deformities like Sherman's disease. And this is to show you, this is the BMD of the spine, and you can see it's full of osteoarthritic bony changes. And usually we look at L4, and you find that L4 is here. The T-score is 4.5. And this means that the T-score here is 4. And this means that this patient by no means is osteoporotic. On the contrary, he has a high bone mass. But actually, this patient, because of the overlap of the osteophytes, it gives us a false reading. The same with hip osteoarthritis, it gives a false reading as well. And if you classify the T-score alone, we miss patients with fractures. This is the classification by the BMD, the percentage of those with fracture. You find that osteoporosis, almost 23% of the patients are having fractures. Osteopenic patients, 20% are having fractures, and normal patients, almost 16% are having fracture. So this is a measurement which, in addition to other things, can be helpful, that we cannot rely on entirely. Mentioned in the discharge summary, 23%, it was mentioned in the discharge summary. Osteoporosis was reported 17% of the patients, but the funny thing, treatment for those patients were only 7%, apart from the 23% even with fracture, they only had treatment. This means that the condition is underdiagnosed and undertreated at the same time. Now the second tool we use is the QCT. It is a flexible measure. It had the advantage of it measures clavicular bone or mixture of cortical and clavicular bone because usually it's on the vertebra. It's have a high radiation dose, low precision. It is expensive and no validation with the WHO. And this is how it looks like because we measure the vertebra. Now the other thing we have is the biochemical markers of bone turnover. We have markers for bone formation. Some we measure it in the serum, like the osteocalcine, and some we measure it in the urine. And we have resorption markers. In this part of the world, we don't use markers very commonly. We rely mainly on the BMD because bone markers are relatively expensive. But the bone markers, we cannot rely on them definitely in treatment. We can rely on them in follow-up, especially when we stop the treatment. They predict bone loss, prediction of fractures, and the most important thing is they monitor settlement. Because when you stop the treatment and you want to see if the patient is losing bone or not, the bone markers will help you much better than the BMD. They complement each other. If we put the BMD and the bone markers, they provide us what is the situation concerning the metabolism. They do not provide any information about the current bone mineral content or the bone fragility. They don't provide any information about a specific side. You cannot say that with this bone marker the patient is losing bone in the hip or the spine. We indeed provide information about the current bone status regardless of the bone mineral content and strength. However, the ability of the markers to predict fractures is not established fully. Bone markers, they are neither substitute, they cannot substitute, but they can complement the DLD measurements, and they cannot predict fractures. We need to do more studies with the bone markers to see where it is to be positioned. Now, if I move on to the incident of fractures, you can see that in women, usually it is vertebral, more than hip and wrist, and the number of fractures that were standard increases with age. And as I was saying, as we live longer, we fracture more bones, especially of the spine. And compared to men, it is much less. The rate of 100,000 men, you can find that the rate is almost 3,000 vertebrae after between the age of 70 and 80 years. The patient will land in a vicious circle, especially females. They have a low bone mass, and then with the first fracture, another fracture is going to take place, and they will have the pain, and it will become inactive, or they will land into an agony state, social isolation, and the vicious circle continues. And this is handicapping to the patient, and the patient starts not to move, and at the same time, the conditions progress. Our objective of treating osteoporosis is we want to prevent the first fracture from occurring. And if we fail in doing this, we try to prevent the second fracture. And the whole idea, we should restore the balance between the osteoclasts and the osteoblasts. The osteoclasts will demolish bone, tired, fatigued, stressed bone, and this condition is mainly monitored by the osteocytes. The osteocytes, these are cells which are present in the bones. They are extremely abundant, and they have mechanoreceptors where they detect any change in the bone architecture, and they will direct the osteoclasts to this site where the osteocytes will go process of apoptosis, which is suicidal death, programmation death of the osteocytes, and the osteoclasts will take over. And after they will take over, they will destroy part of the bone. Osteoblasts will come, lay off a new bone, and this we have what we call bone remodeling. And this remodeling cycle takes almost 6 months. Demolition phase takes about 2 weeks, and the rest is build-up phase. So what is the situation today? Bisphosphonates are still the third choice in treating postmenopausal osteoporosis. And we have seen that the nitrogen-containing bisphosphonates like residuronate, they reduce the risk of vertebral and undervertebral fractures. Unfortunately, most of the drugs which we have, they work much better on the vertebral rather than non-vertebral fracture. And we have improvement in term convenience. We have drugs which can be taken instead of daily, weekly, every 4 weeks. We have injections every 6 months. We have injections every year. And we have injections which is the build-up dose of which is the PTH intermittent, and it's given every day subcutaneously. But the most important thing is adherence, treatment, and compliance, which patients don't like. Now, when they came up with the weekly anti-resorptive instead of the daily anti-resorptive, the compliance didn't change much. On the contrary, if you start with 100 patients, after 6 months, almost 30% are still on the drug. After 1 year, only 20% are still on the drug. Now, what about the conventional bisphosphonates? Adherence is very important. It's highly effective, but oral bisphosphonates are associated with gastrointestinal complications, and the dosing schedule and regimen are not convenient to the patient, and this reduces the compliance. They cause acute phase response, in which there is the bones will go to the osteoclast, and this will cause painful conditions, upper gastrointestinal tract rash, iritis, renal impairment, and jaw osteonecrosis have been reported, but we haven't seen it with patients with osteoporosis, but it's usually seen in patients with cancer and the pathology is not yet known, but it usually occurs much common than with patients with cancer. Now, sometimes patients having anti-resorptive drugs, they fracture, and what we call they have frozen bone, because the bone remodeling cycle is high, the bone turnover is high, but we need between 5 and 10% of the bone healthy, not remodeled, and without increased remodeling to prevent this. And this is the osteoclast, and this is the lining cell, and this is the bone. And then this is the resorption cavity which occurs after the osteoclasts have cleared the bone. Osteoblasts came in, and this had formed the osteoid, and the bone became mineralized, and this defect here has been completely covered by the osteoid. Now, this is the other situation when the osteoclasts come in with a very high bone turnover, not the regular bone turnover, many cavities occur, and what happens here, this is microfractures, what we call stress rises. And these stress rises will occur, eventually leading to perforations, so there is no osteoid here and fractures to take place. Now we have options for the preventions, and we have, this is like a step pyramid, general measures, risk of falls, changing the style of life, analgesia, anti-resorptive drugs, anabolic drugs which are bone-building ones, and then we have alpha-calcidol, which is the vitamin D I'm going to speak about later on, and these are drugs with dual mode of action, like strontium. We don't have combinations, and we don't like combinations because this can increase the side effects and it won't give any added value to the patient. But we have sequential therapy. For example, you give PTH to the patient, you are allowed to give it for 18 months or 2 years, and you have to stop otherwise because it's osteosarcoma, and then you continue with another anti-resorptive drug. But in all these, it is mandatory to give the patient a supplementation of calcium and vitamin D. Now this is a big question, how long to treat? And there's a lot of debate about this. And this is the effect of alendronate after 5 years of treatment. And this is another study of 10 years and what to do. And eventually we came with the conclusion HRT, as short as possible now, it is not recommended for treatment. Raloxifene, which is selective estrogen receptor modulator, it's like HRT but without some side effects like cancer and things like that, no limitation. Teriparatide, 18 months, has been extended now to 2 years. Strontium, we have 5 years studies, bisphosphonates, and controversial studies on denosumab for 3 years. We are looking for a new class of bone-forming drugs like serotonin or 5-hydroxytryptamine. They are important regulators of bone remodeling, and serotonin is sensitizing. It's 2 steps from the amino acid tryptophan, but this is something to look for in the future. Now, ladies and gentlemen, 280 new fractures every hour occur in the world, resulting in 2.46 million fractures in 2010. 34,000 deaths are caused by fractures annually, 80 per day, 49% following fracture. Large gap between the number of people who are treated compared to the number who are eligible for treatment poses a fracture risk because patients are not given the treatment or they don't comply. There is a large gap and inadequate implementation of national osteoporosis guidelines. There is poor adherence to therapy, and this results in low treatment uptake. And with the increased treatment uptakes, 13% of the protected increase in fractures and 20% projected increase in lost quality of life would be cost-effectively avoided. We know now that every 30 seconds, someone in the European Union suffers a hip fracture as a result of osteoporosis, and I believe that this is the time we should tell our patients about osteoporosis, screen our patients who are at risk, because I believe this is a preventive disease. Thank you very much.